Right. Today's topic is about one of the most dreaded things that people who either want to do CESR or are thinking about doing CESR, which is nowadays called portfolio pathway, are most scared of, and that is evidence collection and evidence organization. So what I'll do is I'll take you through a lot of things, including what kind of evidence you need for CESR, how you can produce all that evidence back home, even before taking your first step towards it, and how you can slowly build up all that portfolio which is required to then prove your equivalence to UK trainee specialities and other things. Feel free to pop up any questions that come to your mind during the talk in the chat box, and I will try and answer those in a bit. So for those of you who do not know what CESR is, CESR is essentially a certificate of eligibility for specialist registration, which is now called the portfolio pathway. Although it was supposed to make things easier, but I do not think anything has gotten easier. So it's basically a renaming of the same mayhem that CESR was. It's essentially an alternative route to specialist registration for specialist doctors outside of GMC training. And they do have specialist experiences and they do have competencies. It's just a matter of how you would prove that equivalence with the UK trainees. Now, going ahead, what are the basic pros and cons, and what are the basic key points that allow us to go through the CESR pathway? So we are specialists in our own countries. We carry a lot of experience. We've already had our post-graduation done for many of us. Some of us have done that in a surgical specialty. Some of us may have done it in a medical specialty. Some of us may have cleared a lot of international exams as well. So all of that can be used to then prove equivalence to UK specialty trainees and eventually make your way into getting a CCT. So CESR is essentially a portfolio-based assessment that will help you to demonstrate that you have the skills, you have the knowledge, and you have a portfolio which is comparable, if not better, than the UK trainees who go through the same specialist training pathways, which is what gives them at the end a certificate of completion of training, or CCT. So that comes as the same outcome for us when we complete our CESR portfolio pathway. It's just two different pathways altogether. It is perfect for IMG doctors who have got substantial experience, who've got international qualifications, and who've got a good portfolio. Now, what are the essential requirements? So obviously, if you are supposed to come and work in the UK, you should be registered with the GMC, and there should be a full registration with the right to practice in the UK as a doctor. You should have a primary medical qualification that is acceptable to GMC standards, and you can check that using systems like NARIC and ECFMG. Language requirements, because NHS is heavily English dependent, so a good IELTS score or an OET equivalence score would be essential for coming and working in the UK. And for specialist experiences, different specialities will need different levels of experiences. For example, run-through specialities like radiology and pathology need at least 4 or 5 years of experience post-qualification. Then the uncoupled specialities where there is a core training and there is a higher specialty training. For example, people first going for core medical training in the UK and then specializing in another branch usually takes about 6 to 7 years. And henceforth, if you've got an experience of 8+ years, then you can apply for that. And for GPs, an essential 3-year post-qualification is required in clinical settings. So what's the application process? It's not easy, I would say, but it's not that difficult either if you're a bit organized from the very beginning. So the first step's always you get yourself familiarized with the system. You go through the GMC website and go and look at the specialty specific guidance, which will tell you what the UK curriculum standards are, against which the GMC and the Royal Colleges are then going to compare your portfolio with. So you need to gather all that evidence which is required, all the assessments that are needed, obtain references from your referees, the people that you worked under, and then you have to map your competencies with the curriculum. Once all of that is done, so that's the initial bit, and that is going to take the most of the chunk of your time, which is anywhere between 2 to 5 years. Then you submit the application with a well-formed CV, a summary of your evidence, and supporting documents. It is quite self-explanatory, so I'm not going to go into the details of it, and much more information is available on GMC website. GMC reviews this eligibility. So it basically compares your portfolio of evidence against the curriculum and then provides guidance on what else is required or where you're lacking or where your portfolio is lacking. The specialist advisors in the GMC will then ask you for additional evidence and things. And once you've submitted that evidence, then your application goes to the Royal Colleges, who are then responsible for doing the final checks and who are also the ones responsible to accept or reject your application. Now, if they reject your application, they do give you recommendations and a year from the date of recommendation that you can reapply through the same application after providing additional evidence. The total timeline for a well-done application is about 12 to 24 months from the time you apply, but it again is variable, depends on the speciality, the complexity of the application, and the completeness of your portfolio. Now, the portfolio requirements. So this is the main bit that everybody needs to know and understand. These are the various evidences that are required to actually make a good portfolio. So obviously, I've talked about the curriculum mapping. So you can do that against the specialty specific guidance, which is, on this GMC website. But what else are you going to prepare your application with? So you need what is called workplace-based assessments. And workplace-based assessments are essentially what they do here in the UK. Nimal, would you mind not playing with the marketplace? You're spoiling my presentation. Case-based discussions, DOPs, multi-source feedback, audit and quality improvement projects. These are the kind of assessments that are done by the UK trainees. And these trainees are then, they are sent for an ARCP, which is essentially a panel of experts who then go through all these assessments and tell them what all things they still need doing in that particular year of their training. So obviously, if we take the whole of that training bit together, then we need a good number of these workplace-based assessments from the workplaces that you are working in. And then they should be compiled in a way that shows progression from a novice level to an expert level, and then somebody who can work as a consultant in the UK. The other bits and pieces that you would need is evidence of learning. Evidence of learning would include a very broad, I would say, spectrum of evidence, which includes not just the certificates of the various CPD courses and the various training bits that you've done, but also needs reflections. So reflections is a big part of the UK curriculum, and therefore reflections in the form of either a diary or in the form of a PDF document or a file will form an essential part of your CESR evidence. Obviously, you would need more supportive documentation, for example, your employment references, job descriptions, publications and research, teaching, training activities, leadership, and management experience. I am just going to stop sharing for a bit. Right. So now this is one of the most common questions that I get asked whenever I'm mentoring a CESR trainee, or whenever I'm mentoring somebody who's taking the first steps towards portfolio pathway. And this is essentially what can be done or what can be gathered in your home countries that will then be carried forward to the UK when you get your first job in the UK. And these are essentially the things that you've already done back home, but they need to be in a documentation format for then comparing with the UK trainees and the things that they do. So the portfolio needs to be made while you are there back home, and you can start doing it as soon as you make up your mind that this is something you want to pursue. So the things that you can collect from the home countries is these workplace-based assessments. And in a bit, I will give you a little link which takes you to an exemplar of a workplace-based assessment template, which you can use for all your case-based discussions and your mini clinical exercises or your direct observation of procedures and all of that. As I said, reflective documentation or a diary. I'm going to talk in detail about reflections in some time, but this is something that you can start creating. So start gathering all the nice cases that you're doing back home, all the interesting situations that you've dealt with, or all the interesting people that you've dealt with. So you start writing stories about it in a reflective format, and thereby you collect a diary, which is then available for you to actually submit with your evidence for CESR. And then professional activities. So I came up with this little synonym, just this little acronym just this morning. So you have to show commitment to your specialty. For example, I'm an intensivist, and to show commitment to my specialty, I would do it by taking memberships of professional bodies like Intensivecare Society or European Society of Intensive Care Medicine or Indian Society of Critical Care Medicine, and so on. I would also show my commitment by either attending conferences or doing presentations in those conferences and getting certificates for participation. A goes for audit and quality improvement projects, although this is not something that many countries do, but it is an essential part of your application, as well as it is a very essential part of your appraisals when you work in the UK. So doctors are not just there to treat patients and come home. They're also there to help and improve the quality of care that is provided to the patients. And audits and quality improvement projects are the tools that you can use to improve patient care. Most of the times, I think these things are done by nurses or nursing colleagues who are in a research or an audit or a quality improvement position. But it would be grand if you can also participate in it and get your name onto one of those projects. Research, of course, all the research-based activities that you do, including courses, presentations, or publications, they all form a very relevant part of your application evidence. And teaching and supervision, of course, when you grow in your specialty, you also grow as a person. And from a learner, you then become a teacher, and then you become a supervisor. So all these skills that you obtain during that course of your journey from being a learner to being a supervisor should be evidenced, should be documented, should have certifications, back up by professional diplomas in teaching or departmental teaching presentations, student feedbacks, and all of that. So all of these together gives you a very comprehensive portfolio of activities that you do apart from being a clinician. All right. Very important to know. And as you start gathering all this evidence, keep in mind that you will need English copies of everything. You will need all your evidence in English or professionally translated. So it's better you start collecting them in English to begin with, to then not get caught up in professional translation and how and where and from whom to get it done. Use the UK workplace-based assessment formats. They are freely available on the GMC website. Some of the Royal Colleges also have templates that you can use for collecting evidence back home. These days, there are fillable PDFs which you can use for electronic documentation of the cases that you see or of the procedures that you do supervised. And then also it's very important that if you are collecting all this evidence back home, your supervisors may not be familiar with the formats, with your ultimate goal, the ultimate outcome that you are aiming for. And they need to understand what is it that UK requires from you in terms of giving you a specialist registration. So therefore, have them familiarized with the UK standards, give them examples of how to assess these workplace-based assessments for you, where to take. You might have to even show them one or two so that it's done properly and it looks authentic. So here is a little guideline for writing these workplace-based assessments. I'm just going to give you a little bit in detail about case-based discussions, because I think case-based discussions are really good tools, and you can show a lot of your competencies in just one case-based assessment, as against a lot of smaller assessments or mini cases and ACATs. So for case-based assessments, you can choose a very complex case. You show your clinical reasoning for the case. You discuss with your assessor or with your supervisor regarding the diagnosis, what management you did for the case, what were the complications, and what was the learning from the case. And then you reflect on the case in terms of what went well, what you could improve, what you would do if a similar case happens the next time. 1 or 2 pages maximum per case, and you can come up with an excellent bundle of about 15 to 20 most important cases in your specialty. And that would give you a very, very strong application, at least from the workplace-based assessment side of things. Some of these are these days called the SLEs as well. So both those things practically mean the same. Let me show you a little example of how a form looks like. So this is a CBD form from the Royal College of GPs. And this is how it looks like. You can either do it as a soft copy, you can do it as a hard copy. But of course, if it's a hard copy, you'd have to convert it back into a soft copy for your application process. So you give the details of yourself or whoever your assessor is, what their position is. Do not worry about the GMC number because neither of you would have it initially. And then what you can do is you can briefly describe the case. It gives you a level of complexity, experience. And there is a lot of different things, a lot of different examples available in your specialty specific guidance, from where you can pick and choose the cases that you want to actually discuss and write about. And then you can prep your portfolio. And then at the end of it, it's your assessor that has to then do this assessment bit, whether they think you're capable enough, what level you are at, what is their feedback, and what are their recommendations for you to, better in that area. And all of this can then be cross-referenced with the curriculum, and this can be used as a very powerful evidence for your competency assessments. Similar to this is another one. It's also a CBD format. This is from our COA. It doesn't open, so I'm not going to waste my time here. But you can later open it if you see the recording of this. Anyway, the writing guidelines. So what are the important bits that you need to always remember? 1, choose an appropriate assessor. So an assessor has to be in a supervisory role. So it could be your senior registrar, your consultant, it could be your medical superintendent, it could be somebody in a CMO position or a department head or an HOD. You have to brief the assessor as to what you are looking for and how they need to assess you and what feedback you are expecting from them. Provide them with the context, provide them with the competency requirements that you are looking at for a particular case when you're discussing it with them. and allow adequate time for a meaningful discussion. These days, a lot of people have been using AI for writing their CBDs. I would not recommend AI because this is essentially your own learning, and it is very easy for GMC to catch purely AI made up patients and AI made up scenarios. So be very careful if you're using AI for your portfolio preparation. Coming to quality indicators, again, when you're asking your supervisors to do a CBD or a workplace-based assessment for you, ask them to be specific. Do not be very generic with their comments. Give evidence of structured discussion, clear points of improvement, what they would expect at your level of training. And also, they should give their credentials. If they do not have a GMC number, they should at least give their local registration number or something that binds them with a regulatory body. A pro tip, and this is something that I used for getting my assessments from back home, is you can create a briefing document, like a 4 or 5 line thing that tells your assessor that you're prepping for CESR, and CESR is basically this and that, and then you're going to send them an assessment form, and then you're going to discuss a case with them, and these are the bits and pieces that they would need to then tick you off for. And I found that really useful for my assessors as well. The other evidence bits that you can start collecting back home is patient care documents. And be very careful when you're collecting patient care documents. You might have to use your paper copies and then scan them and then redact them because they need to be anonymized. They should not have any patient identifying information like their names, addresses, phone numbers, even hospital numbers or a generic identification number like Aadhaar number or anything else. So be very careful when you're taking photographs or scans of these hard copies and converting them into soft copies, and be very sure that you have anonymized or redacted all this information. You can use case studies, you can use your ward forms, you can use your clinic letters, you can use your MDT records, care pathways. If you've ever participated in the development or improvement of any protocols, all of these documents can be used for evidence of your clinical as well as your non-clinical competencies. And these will help strengthen your application very much. Now, if you are a doctor, obviously you are involved in a lot of communication, so you can use your patient communication. For example, difficult conversations that you've had with the patient, have a habit of writing those things down, either in the form of a reflection or in the form of a document in the patient notes, and you can use that as an evidence as well. Then colleague interactions, usually conflict resolution or team building or anything that you've done to improvise the well-being of the entire team. Any complex cases that you have ever managed, any ethical decisions that you've ever found yourself caught in, any reasoning that you gave for those ethical dilemmas, and anything that you have done from the EDI perspective. All of these things can be used for reflections. And if you do not have a formal documentation of all of this, then you can make at least a reflective piece out of it. And reflections usually do not need any sign-offs. Reflections are for your personal learning, and it's something that you would create as an evidence for your clinical or non-clinical practice and development. Leadership and management evidence. So again, because you will slowly progress in your career from being a junior resident to a senior resident, and then a specialist or a consultant, and so on and so forth. You will go through the processes of leading teams or supervising the juniors or improving services, doing non-clinical courses, helping in resource procurement or budgeting, rota management, any kind of change that you're bringing about in the unit that you're working in or in the hospital that you're working in as a whole. Collect the evidence for all of those things that you participate in. Now, this evidence can be in the form of emails, it can be in the form of formal letters, it can be in the form of a reflection. Again, it can be formal courses that give you certificates or diplomas and degrees. It could be in the form of a seminar that you attended, or it could be in the form of a presentation that you did yourself for others. So all of those things and feedback that you receive for those things are all super important when you come to consolidating your evidence for CESR portfolio pathway. This is a very easy to use format, which you can use in almost all kinds of situations, whether it's communication, whether it's reflection, or whether it's just writing about a case and how you managed it. So this is also very useful in your interviews when you eventually sit for an interview for an NHS post. I think it's a very brilliant, easy structure to remember, and you can apply it anywhere and everywhere in your documentation. Reflections. So I think most of the doctors who come from other countries, including myself, are very much new to this concept of reflecting. Because back home, we are so overwhelmed with the patients, and we are seeing so many patients at a time. There isn't enough time for us to go back and do our own learning. We are mostly concentrating on exams, reading for exams, writing notes, taking notes, or attending courses and all of that. But for our personal learning, we do not do much reflective practice, which is something I learned after coming to the UK. So reflection is basically what you learn from dealing with a particular situation. Now, that situation could be anything. It could be a complex patient, it could be a clinical error that you got involved in, it could be a serious incident that brought harm to any of the patients and you felt bad about it. So we do this on a regular basis. We do our own critique. But instead of just doing our own critique and forgetting about it later on, we can write it in the form of a reflection. And the usual reflections follow a very nice cycle, which is called the Gibbs reflective cycle. And I would encourage you to go back and read about Gibbs reflective cycle, because it actually tells you how you write a proper reflection. Again, it takes you through the process of describe what's happened, what did you feel about it, then what was good or bad about the experience, analyze why you're feeling that way, and then what you could have done better, and next time, what will you do when you are put in the same situation? There is an example of it. Let me see if I can open it for you. It would... Unfortunately, I'm not able to open this for some reason, but anyway, there are lots of examples present online, so you could go and check it out for yourself. But I'll give you a very easy example. Suppose you are a senior registrar in intensive care and you supervised a junior for her first central venous line. So the description would be you supervised a junior for her first central venous line, and she had a complication as a result, and she was very upset and left the procedure midway, and you had to complete the procedure on her behalf, and later on you had to go and do a debriefing for her. So this is the description of what had happened. Keep it really factual and objective. You don't need to lace it with emotions or thoughts or critique. What were your thoughts and feelings? So at the moment when this happened, you felt bad about the situation, but then you also wanted to support your junior. You were also thinking about patient safety. So you went ahead and completed the procedure yourself. But later on, you wanted to go and have a chat with your junior. And that's how the things will then proceed. What was good or bad about the experience? So the good thing about the experience was no harm was brought to the patient because you were there and you took control of the situation quickly. What was bad about the experience is you were not expecting a junior to behave in that way while she was in the middle of a potentially life-threatening procedure. And so you did not feel good about it, and you wanted to go and have a chat about. But you were also thinking of things like, what if this had happened when you were not around? analysis and why did things happen this way. So then you will analyze the situation. Maybe the junior was a bit less confident. Maybe she was scared. Maybe it was her first posting in ICU. Maybe she wasn't prepared enough. Maybe this was something else was going on in her mind. So you do not know. There are a lot of possibilities which you'd only come to know once you have a debriefing. So what else could you have done? So now you describe your debriefing, and then you can also tell them that you can also write that you would have asked the junior before she went on to do her first CBC whether she was feeling confident, how many she had done before, whether she had needed somebody to scrub up with her during the procedure, has she ever seen a complication of the CBC, and so on. And then the action plan, of course, you'd ask the junior to go and practice with a mannequin first, and then attend a course, and then look at a video, and then try and do more simpler procedures. Maybe try with the femoral first, and then go and do it in the neck, and maybe get supervised for at least 10 CBCs before she could go ahead and do one independently. So this is how your a reflective piece would look like, and this can be used as an evidence for your leadership and management, even teaching and supervision. So these are the kind of examples that you can use for reflection. You can use clinical errors, near misses, complications, as I just described, and the lessons learned from those. You could write a reflection about a serious incident. Of course, you would want to not mention the patient, or you would not want to go very emotional about it, and you have to keep it as factual as possible. Then you can write about difficult cases, challenging things that you have encountered in your practice, treatment failures and what could have been done better, communication issues, conflicts with colleagues, difficult patients, difficult conversations, ethical dilemmas like end of life care or resource allocation. I remember I used to write a lot about staff issues during COVID. And then you can also write about professional development, so the skill gaps that you identified for yourself. Because it's such a personal thing, I don't think it can be used in your assessments or against you for regulatory purposes, but it's for your own personal learning. So, of course, should be honest, should show your vulnerability. It should be authentic. It should sound like it has happened really. It's not a story that you just make up from nowhere. It should have learning outcomes. It should have some action plans coming out of the experience. And again, you can also give some evidence of changed practice. For example, if you've learned something from an incident, how would you apply, or how have you already applied it to your practice? So that gives you a very strong reflection. 10 to 15 such substantial reflection across the curriculum and covering different competencies and learning experiences will give you a quite robust reflective diary. When my evidence for CESR was getting assessed, and in the review letter that you get at the end, almost in all my high lows and all my different bits and pieces was written that I had one or two really good reflections, and they were quite interesting for the examiners, for the assessors, and for the reviewers to read through. And then after that, you can collect the evidence of your employment, the evidence of your work in your home countries, and that will come in the form of employment references. This is super important to get letters of employment or contracts from your various departments that you've worked in, to then set up a chronology of your experience and which hospitals you've worked in, what were your job roles, what were your responsibilities, what have you learned in those hospitals or during those rotations. Should come from a department head or a medical director, and it's more authentic if it's typed on an official letterhead, and if it's got detailed duties, duration of your work with them, along with dates. Sometimes, if there is no official letterhead available, you can ask for their stamps, you can ask for their signatures and their regulatory registration numbers from the local regulatory bodies like the local medical councils. Character references, you can use them as one of your references when you finally submit the application, and these should be from senior medical people who know you well. They are very helpful in showing your non-medical skills like leadership, management, how you are as a person, what you do for your well-being, how you are as a team player, how others perceive your work, how others perceive your behaviors, and your professionalism and your character. So I think these kind of references also play an important role when it comes to applying for jobs, because they show your personal attributes and how you make a difference to other people's lives. Supervisor letters, again, super important. So when you do some of your required rotations from other countries, from back home, it is essential that you get supervisor letters from the people that you have worked under. And these could be your direct supervisors or your training program directors. The supervisor letters have a lot of different templates and formats, but you can make yourself a good template and include things like what period you were under them, which hospital you were under them, what was the level of supervision that was provided, what were the procedures that you did under them, or what were the cases that you saw under them, what was your progress, and how did you develop your competencies in those areas. You should also mention if you were part of a rota, if you were doing on-call work, what kind of clinical areas you were covering, and how did they feel at the end of your rotation with them, that you have developed as a doctor, as a professional, whether you have developed more competencies, you have become more confident, and those kind of things, and how was your overall progression during that rotation. And it can be in the form of a letter, it can be in the form of a template that you can use across different hospitals, across different people. It's nice to have some kind of uniformity when it comes to supervisor letters. Training program letters, not many countries provide training program letters, but you can definitely give things like degree certificates, diplomas, or letters from the medical colleges that you've attended, or letters from the various hospitals that you've worked in, if you've undergone any additional training under them. Again, for these kind of letters, when you're producing this letters as an evidence, provide referees with your CV. These letters should have come from one of those referees, or more of those referees. They should have some sort of connection with the specialty that you're applying for, specific areas of competencies that these particular referees or particular supervisors have helped you with. And of course, to make it seem more authentic, try to get them on the official letterheads with full contact details of the hospitals that you worked in or the supervisor that you worked with. And this is how you'd start organizing your portfolio, even without knowing what comes next. So you can make some folders in your computer under these heads: personal information, curriculum, clinical experience, assessments, professional development, and additional evidence. And then you can make subfolders under those headings, which are given under each section. And then you can keep on chugging your evidence, whatever you are collecting on a regular basis, in those subfolders. So at the end of all of it, you will have a substantial number of documents in all those subfolders, and then it'll become really easy for you to then name the files according to what section they are, which hospital they are from, and then just during your application process, you can then reference and cross-reference them across it. So I think I found this really important when I was organizing my portfolio, that I kept a structure and I followed the structure for everything. Because if you are collecting all these documents haphazardly, and if they're not, if the file names are not proper, then going back and figuring out which paper belongs where is very difficult and time consuming. So do it properly right from the very beginning so that there will be less work for you to do when you actually submit your application. So yeah, that's my master tips for cross-referencing. You create a master index, you can create an Excel file and you can start linking the evidence to the competencies. You can give them numbers or specific file names or initials that you can recognize them with, and then organize them in chronological order. Try to just include relevant evidence. Just because you've got lots of papers doesn't mean that you use all of those papers as evidence. Just use the best ones, the high quality ones. So if you've got, say, 5 CBDs for a patient that had COPD and that you manage, you do not need to put 5 CBDs for COPD. You would just need one that shows that you have achieved a lot of competencies while dealing with that case. So try to avoid duplication as well. Digital formats, so you can use folder structure as I just explained. And yes, and this is very important. So because we are coming from different countries with different languages, and we are all being given degrees and diplomas and certificates, sometimes in our local languages, it is very important that you know these degrees and diplomas and certificates, not the CPD certificates, but certificates that are essential as your primary or secondary qualifications, need to be translated into English before you can actually submit them. And you have to submit the true copies as well as the original documents at times. So who can translate? It could be certified translators, sworn translators, embassy or consulates, and professional agencies. There is an organization called NARIC, NARIC.org. You can go to their website and they have a lot of information on what to get translated, where to get it translated. It even gives you an index of a lot of professional translation services which you can utilize. And it's important that all your degrees and diplomas are translated word to word. They have the credentials and the contact details of the translator for the GMC to go back and check. They are also certified that they're accurate, and they should have the original copy attached with them. Degree verification. So some of the primary qualifications or the secondary qualifications from other countries are used as the eligibility for opening your CESR or portfolio pathway applications here. But these documents will need to be verified. These degrees would need to be verified, again, either through NARIC or through an alternative pathway like ECFMG, directly from the universities that you have received the degrees from, or professional bodies like GMC do it for you as well. When you register for the GMC, I think that is when the degree verification process also happens. It is slightly costly affair if you do it in the UK, so it's much better that it started whilst you're still back home. Logbooks. So logbooks are essentially whatever you do on a regular basis. And this is not just the patients that you see, not just the clinics that you attend. It's also the procedures that you do and how you are involved in the overall patient care in the unit that you're working in. So you need to make logbooks for essentially everything that you do, whether it's procedures, whether it's clinical cases that you've seen, whether it's an on-call experience, emergency cases, decision-making, whatever levels you have worked at, and the participation in multidisciplinary teams. Again, make sure the entries are complete, procedures are all verified, patient identification information should not be there. Again, procedures outside your specialty do not hold any importance when you're applying for portfolio pathways, so do not need to brag. exclude them from the logbook, keep it very minimal, keep it very precise, and keep it as close to the curriculum as possible. You can devise your own format and a template for yourself, and you can use it as you wish. Or you can use one of the e-logbooks that are available online. There are lots of apps that are doing medical logbooks these days. You can use one of them. Some of the Royal Colleges in their portfolios also provide logbook assistance, so you can use their logbooks. So these are the various places that you can get a logbook from. In our countries back home, some of the logbooks are still paper logbooks. If they are paper logbooks, then they would have to be converted into a PDF, and the PDF would have to be then uploaded as evidence because they do not accept hard copies anymore. Things that you would want to provide in a log is essentially date and duration, setting, where did you do what you did, what was the complexity of the case, whether it was a normal case, a complex case, something that led to the death of the patient, what was your role, whether you were just observing or whether you're assisting or you were doing it independently, what level of supervision did you need? Did you need on-spot supervision? Did you need remote supervision, or did you not need any supervision? And then what were the learnings that you obtained from that? Again, focus on quality over quantity. No matter if you've seen 5,000 patients in a span of 5 years, you do not have to make a logbook of 5,000 patients. Just make 1 or 2 patients that you have seen in your workday that has a complex, that is a complex patient, or that has given you some learning, or in that patient you have been involved in a complex procedure, something of that sort. So whatever is more, whatever carries more weight, just concentrate on that, as against a lot of patients in one single logbook. Again, focus on demonstrating your competencies. Make sure it can be cross-referenced with your rota. So, for example, if you've not been on the unit and your logbook says that you've done a procedure on that particular day, it can get you into trouble. So be very careful with how you produce your logbook and demonstrate your competencies. So this is a very quick template that I found on the GMC website. This was used as a template for GP registration. So you can see how simplified it is, and it just mentions the patient's age, gender, what kind of consult it was, what kind of presentation, or you can say diagnosis, and then what was your involvement in that particular case. So you can do anything from admitting the patient, reviewing the patient, ordering prescriptions, doing procedures, doing investigations, talking to the families, doing CPR, end of life care, so on and so forth. So you can tailor it to your speciality and to your competency or your involvement in those particular patients. So there it is. Why portfolio pathway is for some people and not for others. So for me, I think it is a very good way of proving that you are equivalent to a UK consultant in terms of expertise, in terms of skills and competencies. So if you go through the portfolio pathway, one, it is flexible. You don't have to go from one place to another as is done by the trainees, because their training rotations are not under their control. It also helps in the recognition of existing expertise, so you do not have to undergo the whole training process again. You can work while you prepare, and you don't have to compromise your salaries by going into training program and working as a registrar again or as an SHO again. The registration outcome is the same, so you get a CCT at the end of it all, and it is suitable for experienced specialists who are coming here after working as a consultant back home for a few years. The challenges, of course, as everybody would have told you by now, extensive documentation, very high evidence standards, a lot of work, a lot of time is required. You would need, the specialty that you are applying for may or may not have the vacancies. It There might be a potential for additional requirements, and things keep changing every year. So the requirements that are there this year may change next year. And it is an ongoing process, ongoing evaluations and ongoing assessments. So you have to keep in touch with your GMC portfolio to see what changes are being made to your specialty specific guidance, and then cater to those changes when you're applying. Usually 60-70% success rate with portfolio pathway, higher success for well-prepared portfolios. So I've seen all kinds of outcomes from CESR applications. One of my colleagues was able to get an outcome within 6-8 months, and he's now a substantive consultant. For me, it took more than a couple of years. For many of my other colleagues, it took more than one review to actually get through the process. But at the end of it, there is always a bright light. Yeah, and this is probably the more important bit that everybody needs to know: how pricey it is to actually undergo the portfolio pathway. So the prices, of course, with rising inflation rates have increased, but these are just for the portfolio pathway in the table. To get GMC registration, the registration fee initially is £433, and then to retain your name in the register, you give an annual retention fee of £433. So you multiply that with the number of years that you take to actually undergo the portfolio pathway and do the rotations and stay in the UK. I think it exponentially rises with your expenses. So the first bit is, when you apply for the first time, you pay £1,900 with the application. If your application in the first attempt gets rejected by the college and you get some recommendations and you need to reapply, then it's £826 for reapplication. There is some caveat. You can appeal against a decision on your application. There can be a written appeal, there can be an oral appeal, but then again, you have to fish out at least £2,000 to £3,000, depending upon what kind of appeal you want. And that's not all. To make your portfolio sound competitive to the UK trainees, you also have to undergo the essential exams, which are the eligibility exams to just become eligible to participate in the portfolio pathway. And these exams cost you potentially a kidney each. Anywhere about £2,500 for any of the specialty exams in the UK, approximately the same when you do a European exam. And then on top of all of that, you also have to do certain essential courses like ALS, EPOLS, or ATLS. Again, fishing out about £600 to £800, depending upon where you're doing that. And ACLS is not usually accepted in the UK. So they will ask you to do an ALS or an EPOLS, even if you've done one in your home countries. On top of all of that, for example, in an ICM CESR, there is also something called a specialty year. So if you are going to do a specialty year in something like education, you have to give them a formal educational qualification, which can cost you about £3,500, £4,200 a year. And this is postgraduate certificate course in medical education. It, again, depends on the institution you're going to do it with, but everything is super pricey in the UK. Any other diploma to add to your portfolio and make you stand out and give you additional brownie points is going to cost you a hand and a mouth. So my success tip for anybody and everybody who is trying to go through the CESR pathway or the portfolio pathway is make up your mind quickly, start early in your career, maintain your detailed records, have folders with subfolders, and keep on organizing your documents as much as you can right from the very beginning. Make it a habit. Consider professional guidance for complex specialty and borderline cases. There are CESR mentors available, and there are professional services available through the Royal Colleges, which can be used. There are lots of webinars, there are lots of groups available on LinkedIn and Facebook and everywhere else. There is a lot of help available for you to take that first step. These are the basic, I think the basic reasons why many people are not able to get through the portfolio pathway, or they have to pull out in the midst of it. If there isn't enough evidence mapping, if there is inadequate number of assessments. What is a good number of assessment is still very speciality dependent. It's also very much dependent upon what kind of other evidences that you're able to provide. But do remember, workplace-based assessments is only one small part of your overall evidence. So do not concentrate so much on workplace-based assessments that you are not able to then provide evidence for the many other broad sections that are there in the application. Poor documentation, again, incomplete, unclear, poorly organized documents sometimes does not support your application as much as you would have thought. So make sure they are clear, they are well documented, no grammatical errors, they are signed for authenticity, and they've got some kind of evidence to back it up with. Underestimating the time requirements. So it does take time. CESR is not easy. CESR is very time consuming. It can take anywhere from 2 to 5 years to actually go through the whole process of getting your rotations and doing them and collecting the evidence and submitting the application. So be very realistic about your timeline. And if there are other commitments that are preventing you from committing the time that you need for CESR, then you have to prioritize what you need in your life. And ignoring specialty specific requirements. So this is something that's very close to my heart, because my application was rejected on the basis of me being a bit overconfident and ignoring that I needed ward-based medicine as one of the ILOs for which I'd not provided enough evidence, and I thought I would just escape that. But hey ho, I did not. So whatever they write in the specialty specific requirements, please make sure you've got all the rotations done, you've got evidence for each and every competency, and you've got sufficient quality evidence for supporting your application, as well as a good supervisor report to support your application. So the other things that might help with CESR, with the whole process, is early GMC engagement. Although they are slow, but they are very good at suggestions, advice, recommendations. They can take you through the whole process as well if you've got a little bit of a patience. So I would suggest you go through the GMC website. It's quite extensive and comprehensive, and you can go through various links and read a lot about CESR on GMC. But also you can get in touch with them through emails, and now they've also got a WhatsApp group specifically for portfolio pathway. So you can put up your queries through an email or the WhatsApp number, and they will get back to you as soon as possible, which is usually 5 to 7 working days. Professional guidance, there is a lot of that available all over. It's available in the Royal Colleges websites. It's available in a lot of coaching websites. It's available through professional mentors and coaches. And there is a lot of impetus on having CESR leads within the trusts that you're working in. So go and talk to them, or go and find your peers who have gone through the process, or make up a team of people who is going through the process together, because it's just easier to do it together rather than doing it alone. And if there was any issues, making up your mind about CESR, and if you think absolutely this is not for me, this is not something I can achieve, and I need a pathway that is easy peasy and made by somebody else, and I just need to follow the rules and the advice and the pathway, then you can try and apply for a specialist training post. Again, it is very competitive, and now you're competing with the local doctors as well. So it happens through national recruitment. It will help you complete a UK specialty training program and get you a CCT at the end of it. Usually takes between 3 to 8 years, depending upon the specialty that you are going for. Recently, they've also introduced the CESRUK pathway, which is best for subspecialty recognition. So if you've already registered as a specialist in one particular specialty, and if you wanted a subspecialty to be registered as well, then you can go through the CESRUK pathway. So you don't have to train for the subspecialty again, but just collect evidence through rotations for that subspecialty and provide that evidence to achieve equivalence. And there you are. And then, of course, EU EEA specialists can apply for recognition if they've got the EU qualifications that are adequate. They may require adaptations or assessments. They might have to sit for an interview or an exam. But I think all of that has changed quite a bit recently after Brexit. And then comes portfolio development tips. So my absolute advice for people who want to go through the process and who want to start their portfolio preparation right away: map your experience to the curriculum, figure out what is deficient in your competencies, complete the workplace-based assessments in the UK setting if it is possible. And it is completely doable because you can get a job as a registrar or as a locum consultant here in the UK and then go through the process of portfolio pathway by doing the additional rotations that you would require and getting the assessments done. And maintain reflective records. Very important. They carry a lot of weight when evaluating your application. And seek mentor or supervisor support for assessments. If you're not sure, find yourself a CESR mentor or a supervisor who knows the process of portfolio pathway and who'd be able to guide you through it. I was very lucky that I got an appraiser who was able to push me into a portfolio pathway while I was still feeling really lost in my career. And then I also got a mentor in the form of a friend who had already undergone the CESR process, and they were very helpful in helping me out, organize my evidence and figuring out what the deficiencies were and how to get them sorted. So I think having a friend, having somebody you can look at for guidance and advice is very important, as this is a very long pathway and it's quite taxing. So these are the key resources that might help you. You can go to the GMC website and you can just go on to ask the specialty specific guidance for your particular specialty and just read through it word to word. I would just read through it completely and totally, and then figure out where I stand and what I need to do. The Royal Colleges these days have their specialty specific guidance available. They organize workshops, they organize a lot of webinars and seminars that you can attend to get your grips on the process. There are IMG networks available all over LinkedIn and Facebook. Join one of them, join few of them, figure out what other people are doing, how they are navigating the portfolio pathway, and support each other. And then, of course, you can get professional consultants who can help you with the portfolio development and who can also mentor you through the process. For portfolio pathway guidance and mentoring, if you would want any more suggestions or advice, you can either get in touch with me on my LinkedIn account, or you can book a consultation professionally on my website, thecuckoobrain.co.uk/services. So that's pretty much it. Oh my God, I just went for it. So all the best for your CESR journey. Of course, your expertise and experience have value in the UK and everywhere else. So do not be disgruntled. Do not be disappointed if you feel stuck in your career, because very soon you will be unstuck. Go for it if you want to. If you want more time, have a read, have a good understanding of what your career objectives are, and only then decide what you really want to do. Please leave your feedback by scanning the QR code to gain access to some templates that I've produced for myself during my CESR, so I can share them with you on your emails. If you can drop the emails in the feedback as well, I'd be very much happy to help. If there are any questions for me, we'll just now stop sharing and go through the chat. You can put your questions in the chat if you have any. So what if we don't have all cycles of audit in the same project? So Mansi, if you cannot complete a cycle, all the cycles in the project, that's fine. But essentially, they would ask you to complete a re-audit. Of course. Share. Right, here you go. So I don't see any more questions in the chat. Thank you everyone for attending. I would be putting the recording up on my YouTube channel if you would like to go there and have a look again. I'm sorry it was too much information and I just had to ram through it. But yeah, I'm just very happy to support you in any way possible because I know it's not the easiest thing to do. Nishan says, if you have a hello, would they still look at the competencies very closely and nitpick? They would not. So I think the changeover from CESR to portfolio pathway has brought about this one thing that they're not nitpicking on every little thing. But if you are providing high quality evidence that is covering major competencies, you would get away with it. For example, in ICM CESR, there are 30 cases. I'm not sure where I saw the list. I think it's on GMC, if you can see through it. There are 30 cases that are the absolute 30 that they would need the evidence covered for. So even if you can get all those 30 cases covered in the form of workplace-based assessments or CPDs or courses or training or whatever, I think then you have a strong portfolio. Thank you, everybody. Thanks for joining. I would potentially do another session sometime next month, so you're very welcome to attend again. Thank you. If there aren't any more questions, then I will log off.